Mindfulness-Based Relapse Prevention for Substance Use Disorders, A.Pilot Efficacy Trial. This was printed in the HHS Public Access Author's Manuscripts and published in a final edited form October to December 2009 in the National Library of Medicine, National Institute of Health. Abstract. The current study is the first randomized controlled trial evaluating the feasibility and initial efficacy of an 8-week outpatient mindfulness-based relapse prevention MBRP program as compared to treatment as usual, TAU. Participants were 168 adults with substance use disorders who had recently completed intensive inpatient and outpatient treatment. Assessments were administered pre-intervention, post-intervention, and 2 to 4 months post-intervention. Feasibility of NBRP was demonstrated by consistent homework compliance, attendance, and participant satisfaction. Initial efficacy was supported by significantly lower rates of substance use in those who received MBRP as compared to those in the treatment as usual over the 4-month post-intervention period. Additionally, MBRP participants demonstrated greater decreases in craving and increases in acceptance and acting with awareness as compared to TAU. Results from this initial trial support the feasibility and initial efficacy of MBRP as an aftercare approach for individuals who have recently completed an intensive treatment for substance use disorder. Introduction. With rates of relapse following substance use treatment estimated at over 60%. Substance use disorders are often described as chronic relapsing conditions. The most commonly available treatment in many developed countries are 12-step or mutual support groups. Participation in 12-step programs is associated with greater abstinence. However, these approaches may not be clinically indicated for individuals averse to the disease model of addiction, or whose spiritual beliefs and/or lifestyle are in conflict with the 12-step philosophy. As an alternative to 12-step programs, Relapse Prevention, RP, is a cognitive behavioral treatment focusing on responses to high-risk situations, combining skills training with cognitive interventions to prevent or limit relapse. RP has been disseminated for treatment of several types of substance abuse with considerable empirical support. However, relapse prevention suggests promising advancement in treatment. Relapse remains a significant problem for 44 to 70% of clients. Integration of further efficacious treatment components may enhance relapse prevention treatment effects. Mindfulness has been described as paying attention in a particular way, on purpose, in the present moment, and non-judgmentally. Many therapeutic orientations, such as mindfulness-based stress reduction, MBSR, and mindfulness-based cognitive therapy for depression, use mindfulness techniques and practices, leading to growing evidence of its benefits. Research on mindfulness is in the treatment of substance use disorders is beginning to receive attention in scientific literature. Theoretical foundations for integration of mindfulness with traditional cognitive behavioral relapse prevention suggest that mindfulness may help develop a detached and decentered relationship to thoughts and feelings, preventing escalation of thought patterns that may lead to relapse. Via increased awareness, regulation, and tolerance of potential precipitants of relapse, mindfulness may enhance ability to cope with relapse triggers, interrupting the previous cycle of automatic substance use behavior. In the event of a lapse, awareness and acceptance fostered by mindfulness may aid in recognition and minimization of blame, guilt, and negative thinking that increase the risk of relapse. Mindfulness-Based Relapse Prevention, MBRP, is a novel mindfulness-based aftercare approach. Integrates core aspects of RP with practices adapted from NBSR and MBCT. Identification of high-risk situations remains central to the treatment. Participants are trained to recognize early warning signs for relapse. Increased awareness of internal, emotional, and cognitive and external situational cues previously associated with substance use. Develop effective coping skills and enhance self-efficacy. Mindfulness practice included in MBRP are intended to raise awareness of triggers, monitor internal reactions, and foster more skillful behavioral choices. The practices focus on increasing acceptance and tolerance of positive and negative physical, emotional, and cognitive states, such as craving, thereby decreasing the need to alleviate associated discomfort by engaging in substance use. The current pilot randomized controlled trial, RCT, evaluated the feasibility and initial efficacy of MBRP in comparison to treatment as usual among individuals with substance use disorders. The study assessed treatment effects on substance use outcomes as well as key secondary processes involved, including craving, mindfulness, and acceptance. It is hypothesized that participation in MBRP would be associated with greater reductions in substance use and greater increases in mindfulness and acceptance in MBRP versus treatment as usual participants. Discussion. Results of the current study provide evidence for the feasibility and initial efficacy of MBRP, offering empirical support for MBRP as an alternative to standard of care 12-step based or related aftercare programs. Outcomes suggest significant improvement in MBRP versus treatment as usual participants in days of substance use, craving, awareness, and acceptance. Differences were not evident on other aspects of mindfulness, observing, describing, non-judgment of inner experience, and non-reactivity to inner experience. Additionally, although participants in both groups reported a decrease in substance-related programs, decreases were not significantly different between groups. Finally, the analysis of socio-demographic variables, gender, ethnicity, and severity of initial substance use did not show evidence of their moderating effects on treatment outcomes. Good participant compliance reflected in attendance and continued meditation practice supports feasibility of MBRP. Over half of the sample continued formal meditation practice for at least 4 months post-intervention, supporting acceptability of MBRP in this population. Positive course ratings and the absence of significant differences in attrition rates between the MBRP and TAU arms indicated tolerability of and interest in MBRP among participants with substance use disorders. The MBRP intervention appears safe as indicated by lack of reported side effects of adverse effects. Significant decreases were found in overall days of substance use post-intervention among participants in the MBRP versus those in the treatment as usual group. These gains appeared to diminish at 4 months post-intervention, however, with those in MBRP returning to levels similar to those in treatment as usual. This reduction in treatment over time may be attributed to the study design, which entailed MBRP participants returning to the treatment as usual groups following their 8-week MBRP course. The treatment as usual groups did not necessarily foster continuation of practices and perspectives learned in the MBRP. It's therefore not surprising that the MBRP treatment gains were not fully maintained. These findings suggest need for continued support and maintenance following MBRP treatment. Further studies may benefit from inclusion of continuing intervention consistent support, which has been found to improve treatment efficacy in substance use disorders. In view of MBRP's focus on increasing awareness, decreasing judgment, and shifting from reacting to skillful responding, all key descriptors of mindfulness. Absence of significant differences in FMMQ factors representing observing, describing, non-judgment, and non-reactivity is surprising. However, evidence of processes targeted by MBRP is reflected in differential increases in acceptance and acting with awareness, and decreases in craving. A substantial body of literature documents harmful effects of suppression or avoidance of cognitive and affective responses on a variety of psychological and health outcomes. A central focus of MBRP is thus to increase awareness and acceptance of physical, emotional, and cognitive states. Increases in acceptance and acting with awareness reflected in the current study may indicate a decreased need to alleviate discomfort with substance use and an increase in intentional versus reactive behavior. Reductions in severity of craving in the current study may be explained by increases in awareness of sensations, thoughts, and emotions that accompany craving, coupled with encouraging acceptance of and non-reactivity to the craving response. Repeated exposure to triggering stimuli during which participants practice non-reactivity may over time result in habituation, thereby decreasing the intensity of the initial craving reaction. Taken together, results from the current study are consistent with the underlying rationale for mindfulness-based treatments, designed to interrupt reactive behaviors and encourage skillful responses to challenging situations. Further, results are consistent with neurobiological research indicating associations between mindfulness practice and changes in brain regions involved in modulation of arousal and emotion regulation. The current study has several strengths. To our knowledge, this is the first RCT evaluating the efficacy of a mindfulness-based intervention for substance use disorders and the prevention of relapse. The study provides preliminary support for feasibility, acceptability, and efficacy of mindfulness-based therapies for substance use disorders in an ethnically diverse and challenging population with high rates of homelessness and involvement with the legal system, although other acceptance and mindfulness-based treatments or protocols with related components have been applied to substance abuse samples. MBRP is uniquely designed to address the specific needs of this population. The current study also has several limitations. The brevity of the follow-up period restricted the ability to examine effects of NBRP on long-term outcomes. Although research indicates up to 2/3 of individuals relapse within the first 3 months following treatment, rates of substance use remained low in both groups throughout the study, limiting variability and thus power to find significant between-group differences. Although respective self-report of substance use using may present another potential limitation, the TLFB method is considered a gold standard of substance use assessment. However, additional methods such as urine toxicology testing would strengthen the validity of these reports. Finally, due to high attrition, complete data were not available for all participants during the follow-up period. Although attrition in the current study is comparable to studies in similar populations, conclusions that can be drawn about treatment effects for the complete sample are limited. In conclusion, this RCT demonstrates empirical promise for feasibility and initial efficacy of MBRP as an aftercare treatment for substance use disorders and provides preliminary support for the theoretical framework behind mindfulness meditation as a therapy for addictive behaviors. In the tradition of well-established MBSR and MBCT programs, MBRP extends the populations for which mindfulness meditation therapies can be used to alleviate distress and foster fundamental change in maladaptive patterns of behavior.